Welcome back to topic 2. Now we're going to cover part 2, talking about sodium and water balance. And here are your learning objectives. So let's start with water balance. Water is gained orally through food and drink, and some is generated by metabolic processes. Water is lost through the kidneys, the lungs, the skin, and the GI tract. Obligatory urine output, this refers to the urine output that's required to eliminate metabolic waste. So there's a minimum amount of water loss that occurs through the kidneys to remove metabolic waste products. We also have insensible water losses. This is water loss that we don't notice like through the skin and the lungs. In addition, water output by the kidneys can be regulated according to the body's needs, so we can increase our water retention or increase our water output. This intake and output is regulated by thirst and the hormone antidiuretic hormone in response to changes in the osmolality of the plasma and the plasma volume. So how is this regulated? We have osmoreceptors in the hypothalamus that sense an increase in plasma osmolality. They're really sensitive, and it only takes a small change in plasma osmolality of about 1 to 2%. So this change in plasma osmolality would stimulate thirst. Thirst would stimulate water ingestion, which would raise the extracellular water volume, which would dilute the serum osmolality. We also have volume receptors in the vascular system that can sense when we have a decrease in circulatory fluid volume. This takes a larger change, about a 5 to 10% change. So when we have a decrease in blood volume, this also will cause the secretion of antidiuretic hormone, and this will cause reabsorption of water. ADH will cause reabsorption of water by the kidney, and that will increase extracellular fluid volume. A low osmolality and a high blood volume is going to do just the opposite. Wouldn't stimulate thirst, and we would have decreased antidiuretic hormone release. So thirst is a conscious sensation of the need to drink fluids high in water content. This is controlled by that thirst center in the hypothalamus. As I mentioned, we only need about a 1 to 2% increase in extracellular fluid osmolality to increase, to stimulate thirst. A decrease in effective circulating volume can also stimulate thirst, and this may or may not be associated with an increase in extracellular fluid osmolality. But once again, it's going to take a little bit larger response. Finally, we have the angiotensin II, which is a byproduct of the renin-angiotensin mechanism that also can stimulate thirst. Disorders of thirst. Hypodipsia is when we have an abnormality of the thirst mechanism in which a patient has a diminished ability to sense thirst. This can be caused by lesions in the hypothalamus that occur with like head trauma, subarachnoid hemorrhage, or meningitis, or tumors of the meninges. This can also occur, and very frequently does, in elderly people. They just lose their sense of thirst. Polydipsia is when we have excessive thirst. This is normal in conditions when we have water deficit, but it's abnormal when it results in excessive water intake. So number one, we can have inappropriate or false thirst that occurs despite normal levels of body water and serum osmolality. We see this in congestive heart failure and chronic kidney disease, and we also can see it as a result of an increased level of angiotensin. You can also have compulsive water drinking that occurs in some mental disorders such as schizophrenia. antidiuretic hormone, ADH, or vasopressin. So this is made in the hypothalamus and released in the posterior pituitary in response to high plasma osmolality, remember 1 to 2% change, and or low circulating blood volume, about a 5 to 10% change. Now ADH acts on the kidney tubules to stimulate water reabsorption by causing the insertion of aquaporins. So remember, in the kidneys, we're talking about water reabsorption. We're talking about fluid going from the filtrate back into the blood instead of going out in the urine. And this acts in a part of the nephron that's impermeable to water. So this allows the kidneys to fine-tune the amount of water that they need. The first part of water reabsorption in the early part of the nephron occurs automatically and is not hormonally controlled. But then in the latter part of the nephron, this can be fine-tuned, and this is through ADH. As the name would imply, vasopressin, it can also contribute to vascular tone. However, this only does so when it's released in large amounts, such as in response to hemorrhage. A disorder of antidiuretic hormone, in which we either have an insufficient amount or the body is insensitive to it, is called diabetes insipidus, not to be confused with diabetes mellitus, which refers to sweet urine. Diabetes insipidus has a tasteless urine. There's no sugar in it. And this can be due, like I said, either to a deficiency or a decreased response. So central DI, also called neurogenic, is when we have a defect of synthesis and or the release of ADH. This is usually due to some process that affects the hypothalamus of the pituitary, such as an autoimmune response or vascular disease. It can be temporary, like following head injury or surgery. So that's central. Okay, we are not synthesizing enough ADH. Or we can have nephrogenic, referring to the nephrons. So this is where the kidneys don't respond to ADH. This can be congenital or acquired, such as with lithium toxicity and some other electrolyte disorders. In either case, this is going to result in extreme thirst because of the excretion of an excessive amount of dilute urine. So the patient may present with hypernatremia or high blood sodium and dehydration, especially if they don't have access to a lot of water, because they're going to need to drink a lot of water. These patients can excrete upwards of 5-8 liters of water a day. On the opposite end of the spectrum, we have the syndrome of inappropriate ADH secretion. This is where ADH release occurs in the absence of a signal for its released. In other words, when the blood osmolality is normal or decreased. There are some transient causes, such as stress due to severe pain or trauma, surgery. Some narcotics and anesthetic agents can also cause this. Chronic causes include ADH secreting tumors, some central nervous system disorders, infections such as tuberculosis and AIDS. So here we have too much ADH, so we have too much water reabsorption. So this is going to result in excessive water retention, and all that excess water is going to dilute the blood sodium, resulting in hyponatremia. We see decreased urine output with a high urine osmolality. In other words, the urine is very concentrated, but the blood has a low osmolality. The hematocrit is going to be diluted due to the excess water, as is the blood urea nitrogen. Sodium. The normal blood level of sodium is 135 to 145 milliequivalents per liter. Sodium is the main extracellular cation. It's very important in regulating extracellular fluid volume and osmolarity. So remember, we saw that water follows sodium. Sodium is important for fluid movement. Sodium is necessary for the conduction of electrical impulses in muscle and nervous tissue, It's important for the regulation of acid-base balance, and this is through some of the sodium salts, such as sodium bicarbonate and sodium phosphate. And it's necessary for the membrane transport of many substances, such as amino acids and glucose, get transported, co-transported with sodium. So think about, why would retaining sodium cause high blood pressure? Okay, and that's because water will follow sodium, increasing blood volume and thus blood pressure. So how is sodium balance regulated? Well, sodium is obtained in the diet. Sodium leaves the body through the kidneys, and some exits through the skin and GI tract. Things such as vomiting, diarrhea, excess sweating, loss of skin integrity with burns can result in excessive losses of sodium. Sodium regulation is carried out by the kidneys, and is coordinated by the sympathetic nervous system and the renin-angiotensin-aldosterone system. The kidney monitors blood volume and sodium levels. When blood volume and pressure changes, this can cause the sympathetic nervous system to alter the glomerular filtration rate, and thus the rate that sodium leaves the body. Renin is released by the kidneys, and this can result in the activation of the renin-angiotensin-aldosterone system, which regulates sodium balance, as seen in the next slide here. So let's take a look at this. Okay, so in response to a decreased blood volume or blood pressure, which would cause a decrease in perfusion of the kidneys, renal perfusion, would cause the juxtaglomerular apparatus within the kidneys to release renin. Renin is an enzyme which acts on angiotensinogen, which is produced by the liver, and converts it to angiotensin 1. Angiotensin 1 circulates in the blood, and as it goes through the lungs, the pulmonary endothelium releases or has an enzyme called angiotensin converting enzyme. And this enzyme converts angiotensin 1 into angiotensin 2. Now, angiotensin 2 then acts on the adrenal cortex to cause the secretion of aldosterone. And aldosterone is going to act to increase tubular reabsorption of sodium, and at the same time potassium excretion. So potassium is going to go out in the filtrate, and thus in the urine, the sodium is get reabsorbed back into the blood. Angiotensin 2 is also going to stimulate an increase in sympathetic activity, which will help to raise blood pressure. Angiotensin 2 can also cause vasoconstriction, peripheral vasoconstriction, which can cause an increase in blood pressure. Angiotensin 2 can also stimulate the pituitary gland to release ADH, so water then can follow that sodium and be reabsorbed. So together we have water and salt retention, and this is going to increase the effective circulating blood volume, and this is going to increase the perfusion of the kidneys, and thus will inhibit further renin release. Okay, we also have atrial natriuretic peptide or hormone, which has kind of the opposite effect. So this causes sodium natriuresis, or that causes sodium loss in the urine. Water follows sodium, and this would lead to an increase in a decrease in blood volume or blood pressure. So this hormone is stored in granules within the atrium. So if they get stretched by volume overload, they'll release this hormone, cause sodium and water excretion. Okay, which of the following will cause hyponatremia? Okay, take a minute and look at that. Hyponatremia, or low blood sodium. Okay, the answer is the syndrome of inappropriate ADH secretion. So with this syndrome, you're going to retain too much water, and this excess water is going to dilute the sodium body sodium, leading to hyponatremia. Okay, so disorders of water and sodium balance, they kind of have to be considered together because water follows sodium. These disorders can be classified as isotonic, hypotonic, or hypertonic. We can have isotonic contraction or dehydration or isotonic expansion of the extracellular fluid volume with proportionate changes in sodium and water. So here's where we have a change in the extracellular fluid volume, either a decrease or an increase, but without a change in intracellular fluid volume, so it's isotonic. We can also have hypotonic dilution or hypertonic concentration of the extracellular fluid sodium concentration, and this would be due to disproportionate changes in sodium and water. And this is because a change in the osmolality of the extracellular fluid leads to movement of water into, in the case of a hypotonic solution, or out, in the case of a hypertonic solution of the cells. Okay, so let's look at isotonic fluid deficit. So here we have water and electrolytes that are lost in isotonic proportion, resulting in hypovolemia, or low blood volume. This is the most common type of fluid alteration. Causes include a loss of gastrointestinal fluid, such as with severe vomiting and or diarrhea. We can have this with excessive urinary losses, say due to osmotic diuresis. So things like maybe glucose is pulling excess water out of the blood and into the urine. Diuretic therapy, excessive sweating, in which sodium and water are lost in isotonic proportion, which could occur with fever or exercise. Some endocrine disorders, in which maybe we have low levels of aldosterone. Third spacing, where we have fluids that are sequestered in body cavities and no longer circulating. Manifestations of the isotonic fluid volume deficit include a loss of body weight. We would see dry mucous membranes, decreased skin turgor, so when we pull up on the skin it kind of tenses and rather than goes back. A decreased capillary refill, a decreased blood pressure, and a weak pulse because the blood pressure is low. We would see concentration of blood components. So in other words, we'd see like an increased hematocrit. Now, does that mean we have an increase in red blood cells? No. That means instead we have a decrease in water. So it looks like we have more red blood cells, but rather we have more red blood cells relative to the total blood volume because we have less water. There are some other manifestations which are also compensations that help to maintain blood pressure. These include thirst, an increased heart rate, pale, cool skin, and the pale, cool skin is due to constriction of cutaneous blood vessels, and this helps to maintain blood pressure. So it's going to help to increase the peripheral resistance and maintain blood pressure. It's also shunting blood to the core. We also see decreased urine output, and this is going to be due to an increase in ADH and aldosterone. We can also have isotonic fluid volume excess, and this almost always results from an increase in sodium that then is accompanied by a proportionate increase in body water. This is usually caused by a decrease in sodium elimination by the kidney rather than excessive intake of water and sodium. So some of the main causes, we see this with heart failure. So with heart failure, we have decreased effective circulating volume because the heart's not able to pump blood well throughout the body. And that causes a decreased renal blood flow, and that is going to cause activation of the renin-angiotensin-aldosterone system and water retention. Liver failure. The liver breaks down aldosterone. And so in liver failure, blood levels of aldosterone rise, and that's going to cause an increase levels of sodium. In liver failure, we also see decreased effective circulating blood volume and renal blood flow. which would also activate renin, angiotensin, aldosterone system. And then with corticosteroid use and Cushing syndrome, we also see sodium retention, and water follows that sodium. Some of the manifestations of isotonic fluid volume excess include weight gain, an increased blood volume and blood pressure, edema, distended neck veins, a bounding pulse because the blood pressure is high. We'd see dilution of blood components because we have excess water in the blood. That's going to lead to a decreased hematocrit. We didn't lose red blood cells. Remember, we just added water. Dilution of blood proteins and dilution of blood urea nitrogen. Other things we might see, we could see pulmonary edema, ascites, pleural effusion, and other manifestations if the volume excess is severe. Hyponatremia. This is where we have a serum sodium concentration of less than 135 milliequivalents per liter. Now this can present with hypovolemia, low blood volume, euvolemia, normal blood volume, or hypervolemia, depending on cause. Okay, so this is a little confusing, so bear with me here. Okay, so number one, we can have hypovolemic, hypotonic, hyponatremia. Now this is the most common cause of hyponatremia. This occurs when fluid is used to replace, when water, pure water, is used to replace a loss of isoosmotic body fluid. So pure water is hypotonic to normal body fluids. So for instance, we could see this if we have consumption of pure water after the loss of water and sodium during excessive sweating. We can have euvolemic hypotonic hyponatremia. This is when we have retention of water with the dilution of sodium while maintaining the effective circulatory volume within a normal range. This usually occurs with the syndrome of inappropriate ADH secretion. Next, we have hypervolemic, hypotonic, hyponatremia. This is where we have decreased effective circulating volume that leads to increased fluid retention. So we have a hypervolume, but that extra fluid is causing the blood to be hypotonic and causing hyponatremia. This occurs with some conditions such as decompensated heart failure and kidney and liver failure. So although total sodium is increased in congestive heart failure, the decreased circulating pressure leads to fluid retention. Okay, and then the last one, which is kind of confusing, is hypertonic hyponatremia. And this is a special case in which the blood is hypertonic, not due to the sodium, but rather due to severe hyperglycemia, such as with diabetes mellitus. The high blood glucose actually pulls water out of the cells, and that dilutes the sodium, causing hyponatremia. Let's look at the manifestations of hyponatremia. Okay, so once again, we have serum sodium levels of less than 135 milliequivalents per liter. We see a dilutional decrease in blood components, hypoosmolality of the blood, and cellular swelling. We see this unless we have the special case of hypertonic hypernatremia. So this causes a fluid imbalance in compartments and alters the ability of nerves and muscle to depolarize and repolarize normally. Some of the manifestations we see with that are muscle cramps and weakness, decreased deep tendon reflexes, headache, confusion, disorientation, lethargy, seizures and comas, anorexia, nausea, vomiting, diarrhea, and abdominal cramping. The effects on the extracellular fluid volume and blood pressure are going to depend on the cause. Okay, so remember we looked at, is it hypovolemic, euvolemic, or hypervolemic? But usually it's decreased unless the cause is a dilutional hyponatremia. Hypernatremia is when we have a serum sodium level of greater than 145 milliequivalents per liter with a serum osmolality of greater than 295 milliosmoles per kilogram. Now, this increase in osmolality will lead to an increase in the extracellular fluid tonicity, and that will cause water to be pulled out of the cells by osmosis, leading to cellular shrinking. Hypernatremia may be present with hypovolemia, euvolemia, or hypervolemia, depending on cause. So if it's euvolemic, water's pulled from the cells, preventing a change in volume. If it's hypovolemic, that's where the water loss is greater than the sodium loss from the extracellular fluid, resulting in hypovolemia. With hypervolemic, then we have the addition of a hypertonic solution of sodium and water, such as a nurse giving a saline solution that is higher than it should be. So let's look at these causes. Okay, so hypernatremia is caused by a net loss of water or sodium gain. So we could have an acute gain in sodium with rapid ingestion of sodium without enough water, or, as I mentioned in the previous slide, therapeutic administration of sodium-containing solutions. Or we could have a net loss of water, and this could be due to a defect in thirst or inability to obtain or drink water. This can also be due to loss of body fluids, where we lose more water than sodium. And this could occur with fever and respiratory infections, watery diarrhea, and with diabetes insipidus. Okay, so let's look at the manifestations. Well, first of all, we're going to have cellular dehydration, because the extracellular fluid is hypertonic to the intracellular fluid. That's going to pull fluid out of the cells, resulting in cellular dehydration. The cellular dehydration is going to lead to dry skin and mucous membranes, decreased tissue turgor, increased body temperature, and neurological impairment, including decreased reflexes, agitation, headache, and potentially seizures and coma. We can also have decreased vascular volume. Now that's only if the cause is loss of body fluids. With a decrease in vascular volume, we'd see a weak pulse, and that's because we have a decreased blood pressure. Tachycardia, that would be a compensation to help maintain blood pressure, and increased concentration of blood components such as hematocrit. And then other compensatory mechanisms we'd see would be thirst, increased antidiuretic hormone, and a reduced urine output. Okay, so this slide kind of sums up the effect of both isotonic fluid excess and deficit, as well as hyponatremia and hypernatremia on water movement between the extracellular and intracellular compartment. So over here in yellow we see isotonic changes. So we have proportionate changes in sodium and water. So we could lose both sodium and water, and that would lead to an isotonic fluid deficit in the extracellular compartment. So this is going to cause contraction of fluids in the extracellular, the interstitial, and vascular compartments, but it will have no effect here on the intracellular compartment because it's an isotonic change. So a shrinkage of extracellular fluid, no change in intracellular fluid. Or we could have a proportionate gain of sodium and water, and this would result in isotonic fluid excess in the extracellular fluid compartment. So this leads to an expansion of that extracellular compartment, but once again we have no change in the intracellular compartment because it is isotonic. Okay, and then over on the blue side, this is where we have disproportionate changes in sodium and water. So we could have a loss of sodium or a gain of water, and that would lead to hyponatremia. And this is going to cause water movement from the extracellular to the intracellular compartment. Okay, so we're going to see an expansion of the intracellular compartment or cellular swelling. Or we could have a gain of sodium or loss of water leading to hypernatremia. And this is going to cause water movement from the intracellular to the extracellular compartment, resulting in a shrinkage of cells. If you'd like to see this again or see more, you can click here for a separate screencast on this topic. But you'll have to do that from the PowerPoint slides. Okay, then now here are the concept check questions regarding sodium and water balance. You'll want to spend some time making sure you can answer these questions. Okay, moving on, we're going to talk about potassium and calcium regulation and their imbalances. So take a minute to look at the learning objectives. These are the things we're going to be going over. Potassium is the second most abundant cation in the body. Most of it, 98% roughly, is located in the intracellular compartment. So there's only small but very critical amounts of potassium in the plasma. The average values, normal values, range from about 3.5 to about 5.5 milliequivalents per liter. Potassium is necessary for normal nerve and muscle excitability. If you remember, potassium is responsible for muscle and nerve repolarization. Abnormal potassium levels cause changes in cardiac conduction and can be life-threatening. So changes in potassium are of particular concern. Potassium is regulated through intake. It's ingested in the diet. Output is through the kidneys, and the kidneys regulate this through potassium secretion or potassium loss. So when potassium levels are high, the kidneys eliminate more potassium in the urine. At the same time, hydrogen gets reabsorbed in the kidneys, and this leads to a decrease in pH and metabolic acid. So if we have hyperkalemia, this can contribute to metabolic acidosis or cause metabolic acidosis. If potassium levels are low, potassium gets reabsorbed and hydrogen gets secreted, and this can lead to an increase in pH and metabolic alkalosis. Aldosterone. Aldosterone causes potassium secretion while at the same time causing sodium reabsorption in the kidneys. We can also have shifts between the intracellular fluid and the extracellular fluid compartments. So potassium moves in and out of the intracellular fluid compartment in response to changes in serum osmolality, acid-base balance, insulin, and increased sympathetic nervous system stimulation, to name a few. So let's look at the factors that cause potassium to shift into or out of the cells. Factors that shift potassium into the cells include alkalosis, insulin, and epinephrine. Here we see that insulin and epinephrine stimulate the sodium-potassium ATPase pump. And this, as you recall, pumps 3 sodium out and 2 potassium in. So this is removing potassium from the extracellular compartment and putting it into the intracellular compartment. Another thing that affects this is alkalosis. So if the pH of the blood is high, that means we have low hydrogen ions. So potassium can be exchanged for hydrogen, and that will help to raise the pH, lower the pH, or raise the hydrogen ion concentration, at the same time causing potassium from the extracellular fluid to go into the cell, lowering the potassium in the blood. Factors that shift potassium out of the cells would be acidosis, so that would be this just in reverse. If in the blood we have too much hydrogen, hydrogen can go into the cell in exchange for potassium. An increase in serum osmolality, a cell lysis, so the cells break, releasing all their potassium, or strenuous exercise. So hypokalemia is when we have a decrease in serum potassium below 3.5 milliequivalents per liter. This can be caused by inadequate intake, excessive loss, or movement of potassium from the extracellular fluid compartment to the intracellular fluid compartment. Excessive loss can be through the kidneys due to diuretics, metabolic alkalosis, or too much aldosterone. It can be through the GI tract through diarrhea. Movement of potassium from the extracellular fluid to intracellular fluid compartments can occur with alkalosis, like I just showed you in the previous slide. Insulin, for instance, in the treatment of diabetic ketoacidosis, and also beta adrenergic drugs, which stimulate the sympathetic, which mimic the sympathetic nervous system response. Manifestations of hypokalemia are primarily due to the effects on the electrical activity of nerve and muscle. So it can cause anorexia, nausea, and vomiting, constipation, and paralytic ileus. Paralytic ileus is like a non-functional bowel. There's no peristalsis. Muscle weakness, cramping, and fatigue. Paralysis, once again, both those paralysis and paralytic ileus are only in severe hypokalemia. Paresthesias, those are like the pins and needle type feeling. Postural hypotension, cardiac arrhythmias, metabolic alkalosis, and an increased thirst and inability to concentrate urine. Hyperkalemia is an increase in serum potassium levels greater than 5.5 milliequivalents per liter. This can be caused by renal failure, which is the most common cause, and that's with kidney failure. We have a decreased glomerular filtration rate, so we're just not able to rid the body of enough potassium. Hypoaldosteronism, so we're not secreting enough aldosterone, because remember, aldosterone causes potassium secretion. Some potassium-sparing diuretics can lead to too high of potassium. Movement of potassium from the intracellular fluid to the extracellular fluid, which can occur with like trauma, burns, acidosis, and excessively rapid rate of administration of potassium when treating hypokalemia. Manifestations of hyperkalemia are mainly related to a decrease in neuromuscular excitability due to the effects on resting membrane potential and nerve and muscle. We get nausea, vomiting, diarrhea, cramping, muscle weakness, paresthesias, paralysis with severe hyperkalemia, and risk of cardiac arrest with severe hyperkalemia. Okay, as I mentioned, some of the most serious effects of potassium imbalance are on cardiac muscle cells. With hypokalemia, we see a decreased resting membrane potential. If you think about a resting muscle or neuron, potassium is leaking out of that cell down its electrochemical gradient. Now, if the extracellular fluid potassium is lowered, this is going to create a greater gradient and more potassium is going to leak out. And this is going to make the resting membrane potential more negative. One of the things this is going to do is cause a prolonged PR interval, because it's going to take just kind of more time to reach threshold. This is also going to result in a prolonged ventricular repolarization. This can be seen here with a depressed ST segment and a low T wave. We can also see this prominent U wave. This can lead to ventricular arrhythmias. Hyperkalemia, we have a delay in atrial depolarization, and this is going to result in a PR prolongation with a low P wave. We get a delay in ventricular depolarization, which leads to this wide QRS complex. Conversely, we get a rapid repolarization, and that's because we have so much potassium in the extracellular fluid, it just runs back into the cell. And this repolarization wave, the T wave, is now tall and peaked, okay, and narrowed interval, because repolarization occurs more quickly. Hyperkalemia leads to serious electrical abnormalities that can lead to ventricular fibrillation and cardiac arrest. Okay, let's talk about calcium. Normal serum level of calcium is about 8.5 to about 10.5 milligrams per deciliter. Most calcium in the body is found in the bone, with small but critical amounts found in the intracellular fluid and even less in the extracellular fluid. Serum calcium is found in three forms. It can be bound to plasma proteins, complexed, and free or ionized form. And that's that ionized form that is most important for neuromuscular and cardiac function. It's involved in nerve stability, muscle contraction, and calcium acts as a second messenger in many hormone and neurotransmitter pathways. Okay, so how is calcium regulated? Calcium balance reflects intake, GI absorption, bone resorption and formation, and renal excretion. Parathyroid hormone and vitamin D are the hormones that act to regulate calcium. So calcium in the diet gets absorbed into the intestine, and this is through the actions of activated vitamin D. Vitamin D is activated by the kidneys in response to parathyroid hormone released from the parathyroid glands. Calcium stored in the bone can be released from the bone in response to the body's needs, and this is stimulated by parathyroid hormone. So parathyroid hormone activates osteoclasts, which break down bone and release calcium into the blood. The kidneys play a role by activating vitamin D, as I mentioned, to increase calcium absorption in the gut. The kidneys also cause reabsorption of filtered calcium, which is stimulated by parathyroid hormone. So we have decreased calcium elimination. At the same time, it causes increased phosphate elimination. So when the osteoclasts break down bone, they release calcium and phosphate, but phosphate elimination gets stimulated while calcium absorption gets stimulated. So it's a way to break down bone and just get calcium to increase without phosphate. With hypocalcemia, our total serum calcium is less than 8.5 milligrams per deciliter. It's caused by, number one, an impaired ability to mobilize calcium in bone. So for instance, if parathyroid hormone was low, or with magnesium deficiency, because this can decrease parathyroid hormone release. We can also have abnormal losses from the kidney. In renal failure, we see decreased activation of vitamin D, as well as hyperphosphatemia and hypocalcemia. And number three, we have increased protein binding or chelation, and this is going to lead to less free calcium, or less of the ionized form. Alkalosis can increase binding, and free fatty acids can increase binding, which we see with stress or pancreatitis. Okay, let's talk about the manifestations of hypocalcemia. With mild chronic hypocalcemia, it's usually asymptomatic, whereas large or abrupt changes lead to increased excitability of nerves and decreased calcium for cardiac muscle contraction. So the increased neuromuscular excitability can lead to paresthesias, particularly around the mouth, hands, and feet. Can lead to tetanus or tetany, a muscle spasm, particularly in the face, hands, and feet. Laryngeal spasms, which can lead to difficulty breathing, and seizures in severe cases. Now, if you remember, cardiac muscle requires extracellular calcium for contraction. Cardiac muscle works by extracellular calcium comes in and induces further calcium release from the cardiac sarcoplasmic reticulum. So without enough extracellular calcium, this is going to lead to weaker heart contractions. Weak heart contractions are going to decrease cardiac output, and that will lead to hypotension. Can also lead to cardiac arrhythmias and cardiac insufficiency. Now the effect on the bone is going to depend on parathyroid hormone levels. So if we have hypoparathyroidism, not enough parathyroid hormone, that's not going to break down the bone. However, if we have low calcium levels because of another cause, and that causes an increased release of parathyroid hormone, this is going to cause a breakdown of bone, leading to osteomalacia and bone pain as a result of that chronic calcium deficiency. Hypercalcemia is when we have serum calcium level greater than 10.5 milligrams per deciliter. This can be caused by, number one, increased bone breakdown, which can occur with malignant bone tumors, hyperparathyroidism, so that's too much parathyroid hormone, and that can occur with those paraneoplastic syndromes, remember, such as maybe having a lung tumor that's secreting parathyroid hormone, benign parathyroid tumors that secrete too much parathyroid hormone, or demineralization due to immobility. So with immobility, the bone can break down. Number two, excessive vitamin D can cause us to absorb too much calcium from the diet. And then drugs such as lithium and certain diuretics. Okay, so what are the manifestations of hypercalcemia? So high calcium levels leads to depressed neuromuscular activity. So we see muscle weakness, loss of muscle tone. You can see lethargy and personality changes, stupor and coma, anorexia, nausea, and constipation. You can also see an inability to concentrate urine and exposure of kidney to increased calcium concentration. This can cause polyuria and increased thirst, renal insufficiency, and kidney stones because of that supersaturation of the filtrate with calcium. Now, because we have excess calcium in the extracellular fluid, we get more calcium coming in with cardiac muscle contraction, and this is going to lead to an increased strength in cardiac contractions. This can cause arrhythmias such as short QT and AV block. It can lead to increased strength of cardiac contractions, all that excess calcium coming in, and that's going to lead to increased cardiac output and increased blood pressure. The effect on the bone is going to depend on cause. If it's caused by too much parathyroid hormone, then that parathyroid hormone is stimulating bone breakdown, leading to osteomalacia. Okay, you'll want to take a few moments to look at these concept check questions, and then I have some other questions for you to go through and answer. Instead of reading you the questions and answers, I'm going to go slowly through the slides and let you take a look at them. Okay, that's it for Topic 2, Part 2. We'll see you for Topic 2, Part 3, Acid-Base Imbalance in the next screencast.